Now, talking a little bit about patients who suffer psoriatic arthritis in general, are we getting to a point where it is becoming easier and easier to treat? We have enough frontline treatments that, if as long as we get everything um, early enough, we could treat them fairly easily.
No, I wish I could say that. It's just like with RA, rheumatoid arthritis, where we still have many new therapies in development. We're having new therapies in development for psoriatic arthritis as well. We don't even have as many choices with psoriatic arthritis as we do with rheumatoid arthritis. But none of these diseases are curable. So we actually need more therapies, and we have persistent unmet need because even if we start treating people early, we run out of options for them over time because these are lifelong diseases.
Now, is there a specific patient population within psoriatic arthritis that is particularly difficult to treat, whether it's age-based or race-based, just a specific group where treatments are becoming less effective than others?
I'm not sure. What we do know is that with psoriatic arthritis, there are like 5 large types of arthritis. So it's more heterogeneous than rheumatoid arthritis. Now, the TNF inhibitors work across all these different types. We also have the IL-17 inhibitors, which are very effective. And now we're getting IL-23 inhibitors. So these are 3 different classes. But what happens in psoriatic arthritis is there's more obesity, there's more comorbidities, there's more cardiovascular disease, there's more depression, there's more liver disease, NASH, so that patients in general are a little bit harder to treat because of this. And so it does sort of appear that psoriatic arthritis can be more challenging. And that's also because there's delays in the diagnosis. Patients will walk around with psoriasis and they're hurting, but nobody sends them to a rheumatologist so they can find out they have arthritis that might be treated differently than the skin disease.
Now, talking about NASH, NASH is one of those focus areas lately, um, because there's probably some diagnosing problems because you need a liver biopsy. Um,
Right?
how can better research into psoriatic arthritis improve treatment for NASH if they're so common as a comorbidity?
Well, I think part of it is if you treat the underlying disease, you may actually be helping the NASH. Okay, because it is part of that obesity spectrum. Um, as to whether I can really tell you that it's going to make a biggest difference or not, I think it's just the combined treatment of these patients and paying more attention to everything that's wrong with them.
Does the kind of large book of comorbidities, so to speak, does that make it, is that where our kind of gap in treatment is because there's so many comorbidities and there's so much, and I guess the obesity complicates it?
That's part of it. That's part of it. Part of it too is that patients tend to fall into however the disease starts. So we think that about 30 to 50% of patients with psoriasis get psoriatic arthritis, but a lot of the time they get the psoriasis first. So their mindset is about their skin. And then, patients don't necessarily know what arthritis looks like or feels like. And so they may not complain enough to see somebody who can tell them that that's what they've got. So that does seem to be a lot of it. But I think you're right that there's just more things that bother psoriatic arthritis patients. We also know that they have a higher level of depression and suicidality, and that we've seen from clinical trials. So those things all sort of compete to making it less easy for a patient to respond.